Well, hello. This is chapter 6. We are going to discuss the beginning, which is mainly all the anatomy, and we are going to talk about positioning for toes and for the foot. So here we go. When we look at the lower limb, basically chapters 6 and 7 are going to take us through the bones of the pelvis, the hip joint, the femur, the tibia, the fibula, and all the bones of the foot. And we're going from inferior to superior. So chapter 6 takes us mainly up to the knee, and then chapter 7 we cover femur, hip, and pelvis. When we look at the bones of the foot, you can see a little bit of this is cut off, but hopefully you can tell that what they're referencing that we have 14 phalanges here. This is just like the hand, so a lot of this correlates. So if you've got the hand down, then this should not be difficult at all. The hand is challenging because it's the first time, but now that you've got the hand down, the foot should be very easy compared to that. When we look at the phalanges, there are 3 phalanx in each of the digits 2 through 5. Remember, we have proximal phalanx, middle phalanx, and distal phalanx. And each phalanx has a head, a body, and a base, just like the metatarsals. But the first digit, just like the thumb, only has a proximal and distal phalanx. So when you add them together, you have 3, 6, 9, 12, 13, 14 phalanges. We can also reference these as our toes or digits 1 through 5, just like the hand. Then we have 5 metatarsals, which also have a head, a body, and a base. At the base of the 5th metatarsal, we actually have a tuberosity that we will discuss. And that tuberosity is an attachment basically for a tendon. And a lot of our images have to include this tuberosity at the base of the 5th metatarsal because it's a very common trauma site for the foot. So it usually has to be very well visualized because of the injury that takes place to that 5th metatarsal tuberosity. And then we have our tarsal bones, of which there are 7. Unlike the hand, there were 8 carpal bones, but now we have 7 tarsal bones. And that totals 26 total bones in the foot. So 7 tarsals, 5 metatarsals, and 14 phalanxes that make up the phalanges. When we look at the joints in the foot, they are very similar again to the hand. We have tarso-metatarsal joints. Like we had in the hand, we had carpo-metacarpal. So these are tarso-metatarsal joints. And then we have proximal interphalangeal joints and distal interphalangeal joints. In the first digit, we have the metatarsophalangeal joint. They're pointing out here. You also have them in each of the digits 2 through 5. So in metacarpal phalangeal joints, we have metatarsophalangeal joints. And then just like the thumb, the first digit of the foot only has an interphalangeal joint, just one IP. And the other digits 2 through 5 have a dip and a pip. Okay, so tarsal bones, metatarsals, phalanxes that make up the phalanges. We have tarso-metatarsal joints where the tarsal bones meet, the tarsal bones of the foot meet the metatarsals. And then you have metatarsophalangeal joints where the metatarsal connects to the proximal phalanx. We have interphalangeal joints, and the first one would be the proximal interphalangeal joint between the proximal phalanx and the middle phalanx, and the distal interphalangeal joint, which is between the middle and distal phalanx. We also have in the foot, we have sesamoid bones. Just like we talked about, we had sesamoid bones in the thumb that come from friction, and we talked about the fact that the patella is the largest of the sesamoid bones. In the foot, they actually have names, and they're named in relation to where they sit. So the one that sits more medial is the tibial sesamoid bone because the tibia is medial. And the fibula is the lateral bone of the lower leg. So this one is called the fibular sesamoid bone. So you have a tibial and fibular sesamoid bone in each of the feet. As far as the tarsal bones, like we said, there are 7 tarsal bones, and we'll actually look at a mnemonic to remember those. You have the calcaneus, which makes up your heel. You have the cuboid. You have 3 cuneiforms, and these cuneiforms can either be called the first, second, and third cuneiform, starting medially, so it would be first, second, and third cuneiform, or they can be referred to as the medial cuneiform, intermediate cuneiform, and lateral cuneiform. Then you have your navicular bone and your talus, and those make up the 7 tarsal bones of the foot. The mnemonic we usually use is "Come to Colorado, next 3 Christmases." So come to Colorado, you've got calcaneus, 2 for talus, Colorado is cuboid, next is navicular, and 3 Christmases refers to the 3 cuneiforms. So come to Colorado, next 3 Christmases, and that correlates to the 7 tarsal bones right here. When we look at the navicular, the cuneiforms, and the cuboid, the picture looks kind of small, but you can see how they relate to each other. You've got the heel of the foot. The talus actually joins with the tibia and fibula to make your ankle joint. And then you've got your navicular on the medial aspect, because this is first digit. Your cuboid is lateral. And then you've got first, second, and third cuneiform, or medial, intermediate, and lateral cuneiform. And then they show you also from a lateral view. And you can see how the foot actually arches. Now, speaking of the arches of the foot, we have 2. We have a longitudinal arch, and we have a transverse arch. Those are the 2 arches of the foot. So the longitudinal arch basically are these right here. You can see looking from the lateral aspect. So if you were standing on the patient's lateral side, and this is the 5th digit, and you were looking, or you were to look in the mirror at your own foot from the lateral side, typically the arch is not very significant that we see from the lateral aspect. But when you look at the longitudinal arch from the medial aspect, meaning this is first digit, when you look here, this is typically where you see a significant arch, much more so than laterally. So when we talk about people having like a high arch or people being flat foot, this is where they're actually looking. They're looking at the longitudinal arch from the medial aspect of the patient. Okay, and then we also have the transverse arch. And the transverse arch is primarily located along the plantar surface of the tarsals and the tarsal metatarsal joints. And it's made up of the wedge-shaped cuneiforms. Remember, we have first, second, and third cuneiform. Okay, so transverse arch, again, medial, lateral. Remember, cuboid sits lateral. First cuneiform sits medial. But the one we typically look, especially when we do central ray on AP foot, you tend to want to evaluate the patient's longitudinal arch from the medial aspect. Okay, so that's the one we typically look at. And this found on page 215. Everything we've looked at so far has been found on either page 212, 213, 214, and this is on 215. If we look at some of the anatomy to review radiographically, the anatomy of the foot in the lateral view, you can see everything pointed out and labeled here. This is the tibia. You've got the calcaneus right here. The calcaneal tuberosity is letter C. Then you've got the cuboid bone. The 5th metatarsal tuberosity is letter E. F, you can see the cuneiforms, all 3 are superimposed. G is the navicular. Looks like I forgot the R on that, sorry. G is the navicular bone. H is the subtalar joint. And then I is the talus bone. And this is on page 217. When we look at the oblique foot, as far as the anatomy, much more anatomy on this, but when you look at letter A, this is the first interphalangeal joint. Okay, the first digit only has an IP or an IP joint. B represents the proximal phalanx of the first digit, and this is all a right foot. So it would be right first interphalangeal joint, right proximal phalanx, first digit. Okay, this is the first metatarsal phalangeal joint right here. D is the head of the first metatarsal on the right side. E is the body. F is the base of the first metatarsal. G is the intermediate or second cuneiform. H is the navicular. I is the talus. J is the calcaneal tuberosity. K is the lateral or third cuneiform. L is the cuboid. M is the tuberosity at the base of the fifth metatarsal. N, you have the fifth metatarsal phalangeal joint of the right foot. And O is the proximal phalanx of the right fifth digit. So all of these should have right in there, but instead of typing that all out, I just wanted you to recognize it's all the right foot, because this is the first digit or the great toe, and this is the pinky. And in order for the foot to be like this for the oblique position, it has to be a right foot. All right, when we look at the joints of the lower limb, this is actually found on page 223. And this is pretty much everything we'll cover in this chapter. We'll talk about the joints in the foot. We will actually look at the calcaneus as well. We'll look at the ankle joint, and then we'll look at the fib, and we'll also look at the knee joint. Okay, but you have a patellofemoral joint between the patella and the femur, the knee joint. You have a proximal tibiofibular and a distal tibiofibular. So if you think about it, the foot is like the hand, the ankle is like the wrist, the tib-fib is like the forearm, because remember you have a proximal radial ulnar joint, distal radial ulnar joint. So here you have a tibiofibular joint, proximal and distal. So once you learn and master the upper extremity, lower extremity is much easier as far as understanding. As far as some of the surfaces of the foot, this is also on page 223 of your positioning book. And as far as the surfaces of the foot, you can see that you have the dorsal surface, which is the top. When you're doing the AP, you're actually doing a dorsoplantar projection, because the dorsum is the top of the foot. The plantar portion is the bottom of the foot. Okay, so if you were doing it PA, you would do a planto-dorsal projection. And then so these are just some, let me go back. These are motions of the foot that you utilize, and it's easier to see on the next slide. So when you dorsiflex your foot, with dorsiflexion, that is where you're actually pulling your toes up towards your tibia and fibula, like you're flexing your toes. Plantar flexion is where you're pointing your toes downwards, okay, away from the tib-fib. And then we have inversion and eversion. Now these, we don't typically do these a lot, but if you remember me talking about stress views of the ankle, that's where it comes in, where you invert the foot, turn it towards midline, and evert the foot, where it's going laterally or away from midline. So these are some different motions we have between the foot and the ankle. So we have dorsiflexion, which sometimes we have to do that with the foot and the ankle. We try and make the plantar surface perpendicular to the IR. You have plantar flexion, inversion, eversion. Now, when we look at some of the technical positioning considerations, we are always typically, with everything we're going to talk about for the next few days, we're going to be at a 40-inch tabletop. meaning your IR is going to be on the table, not in the bucky. We do recommend gonadal shielding for all patients to protect from scatter, especially because you're now at lower extremity. And sometimes when we angle the central ray, when we're angling cephalic, you're actually aiming towards the gonads more so with the central ray, so more important to shield. We should see four-sided collimation. Your part should be in the center of your IR, meaning where those crosshairs meet up in the middle of the IR. That's where your center anatomy should be. And then we should see collimation on all four sides. You want correct part and central ray alignment, meaning your part should be parallel to your IR, and your central ray should be perpendicular to the part and to the IR. And as always, we want to use the proper anatomic side marker. And it's going to play out just like it did with hand. When we do toes, it can go across the toe. It doesn't have to go up and down. But then everything else, now toes will hang toes, foot, ankle, will all hang toes up. Once we get to tib fib, it will actually hang knee up. So marker will still go on the lateral aspect of the part. As far as technical considerations, our KVP range is 65 to 75 KVP. We always want a short exposure time if possible. Small focal so we get the most amount of resolution, spatial resolution that we can. You want to have adequate mass, and we're only going to use a grid for any anatomy that measures over 10 centimeters, which is equivalent to approximately 4 inches. When we look at imaging of the toes or the digits or the phalanges, whichever you want to call that, they actually start on page 228. And if you look and correlate this with your cheat sheet, you notice that with toes, they're just like fingers, meaning we have 3 positions for each of the toes. Some of them require medial rotation, some require lateral rotation, just like they did with the fingers. But we have an AP for all 5 digits. We have a 45-degree oblique, but on some it's a medial oblique, some it's a lateral oblique, and we always have a lateral on the toes. Okay, and the marker gets placed above the digit just like it did with fingers. So for the AP toes or AP digits, notice on page 228, it says that your central ray is 10 to 15 degrees posterior to the metatarsal phalangeal joint. So you can see by the demonstration of the central ray, it is coming towards the heel, 10 to 15 degrees, or towards the calcaneus. And what this does is make your central ray perpendicular to the phalanges, because that's what we're looking at is the toes, correct? And the toes kind of curl. If you ever look down at the foot, your toes tend to curl. So by angling that central ray, or in the next slide we'll look, you can put the patient on a sponge. You're going to make the central ray perpendicular to the phalanges by doing either of those 2 things. Either angle the central ray 10 to 15 degrees posterior, or use a positioning sponge. And your technique for toes is KVP at 0.8 mass. And the marker placement on here is not correct because it would hang toes up. So what you would actually want to see is that marker, and then you would want the right to read properly. So opposite of what it is right here. All right. Like I said, if you don't want to angle the central ray 10 to 15 degrees posterior, you can use a 15-degree wedge sponge, like they show you right here. Again, marker should be the opposite way. It should be the other way so that when this hangs toes up, that reads correctly. So you can place the patient's toes on that 15-degree wedge, and then the central ray remains perpendicular because you're achieving being perpendicular to the phalanges by elevating these toes 15 degrees. All right, and the central ray for AP toes is perpendicular to whatever metatarsal phalangeal joint you are looking at. So this says second digit on this, so you're perpendicular to the second metatarsophalangeal joint, just like they were in this last one without the sponge. You've got first digit, second digit right here, metatarsophalangeal joint. Okay. Now the collimation on this should be a little tighter. When we look at the image, you'll notice that you don't ever get all of the toes in one image. It's confusing for the radiologist to have all the toes in there, or more than ideally the one that is of interest. So when the image comes out, ideally you can tell that this is the digit or the toe of interest. Even though they have a little bit of this one and a lot of this one, the marker, in theory, if this was done correctly, the marker should be right over the toe that you're actually imaging. That way, it wouldn't be an issue. The radiologist would know. So it could be like that or the other way. It doesn't really matter. There's not usually enough room to place the marker. Like you wouldn't want to take the time or open it to place the marker this way. So just putting it across the toes like this is perfectly fine, okay? But this is the toe of interest, and on toes, you have to get a minimum of the distal half of the metatarsal included. So you can see distal, oops, on my pointer, distal phalanx, middle phalanx, proximal phalanx, and then all of this is metatarsal, and we only need at least half of the distal portion, so that is more than sufficient. Okay, and that is an AP toe. Notice it says you need the entire digit, minimum of the distal half of the metatarsal. You want no overlapping of soft tissues if you can help it. You want the interphalangeal and metatarsophalangeal joints to appear open depending on which toe you're doing. Okay, so metatarsophalangeal joint is open as well as the interphalangeal joints are open. Perfect, which means that either the toes were put on the proper degree obliquity sponge or the central ray was angled appropriately. And the exposure factors are definitely optimal. Then we do an oblique of the toes. Okay, and I have on your cheat sheet that we typically do a 45-degree either medial or lateral oblique. Okay, so it's AP between 30 and 45-degree medial or lateral. I would tell you that we typically do a 45-degree oblique. So again, anytime you have an oblique, you need a degree and a direction of rotation. The central ray is still perpendicular to the metatarsophalangeal joint, and the only reason they have the sponge is to help the patient to hold that foot still, because if they were just holding it like that without the sponge, sometimes it can be a little bit challenging. So you can use the oblique sponge that we tend to use when we did upper GI or BE. That 45-degree oblique sponge is perfectly fine to use. And again, in both of these images, this marker is upside down, because if this hangs toes up, then that will be upside down to the radiologist. So it should be flipped. On first and second digit, it is actually a medial rotation so that you reduce OID. So for first and second digit, you would want to medially rotate the foot or towards midline. And for digits 3 through 5, 3, 4, and 5, it would be a lateral rotation so that you get less OID. Okay, so digit 1 and 2, you're doing a 45-degree medial oblique. Digits 3, 4, and 5, you're doing a 45-degree lateral oblique. When you look at the images, now I added this in just so you could see that they kind of, I mean, you really wouldn't be able to tell what that marker was. So I added this right marker in because it should hang toes up and read correctly for the radiologist. So with toes, you need the digit and a minimum of the distal 1/2 of the metatarsal. You need the interphalangeal and metatarsophalangeal joints to appear open. Notice there's an increase in concavity on one side of the shaft. So notice like on this side of the proximal phalanx, it's a little bit concave, but this side there's an increase in concavity, meaning it's more concave. It dips in more on this side than it does on this side. Same thing over here. This dips in way more than this side. And that's normal when it's an oblique. Okay, so this is evaluating the oblique toes. The heads of the metacarpals, that should not say metacarpals, that should totally say metatarsals, should not be overlapped. Big oops right there. Here, let's change that right now. Metatarsals. Metatarsals. Heads of the metatarsals should not overlap. And you want optimal exposure factors. Okay, and that is your oblique toes. And then we do lateral of the toes. Now, let me tell you, fingers are a lot easier to position the patient and have the patient hold than toes. Some people have a lot of dexterity with their toes. They can separate them out. They can hold them in position. Some people not so much. So you notice in here that tape becomes one of your best friends. You can tape toes out of the way. You can put one of the tourniquets that we use in the lab around the toes and have the patient hold it. You can use gauze. You get very creative, but anything you use, whether it's tape or gauze or a tourniquet, you want something relatively radiolucent so that you're not obscuring anatomy. And you always want to tell the patient why you're doing that, which would be to isolate the first digit, to help the patient hold still, to move anatomy out of the way. Whatever the case is, just communicate with your patient, and they're very willing to help typically. Now on the lateral, first and second digit, we actually do a lateromedial. And this goes back to if you're standing in anatomic position and you're looking at the first and second toe, with the patient able to roll this way, they're rolling medial, which means that the lateral aspect of the toe, the projection is going through the lateral aspect, exiting the medial aspect. Okay, it's going in the lateral aspect, exiting the medial aspect. So it's a lateromedial lateral, the first and second digit, and the central ray is to the interphalangeal joint for the first digit. For digits 2 through 5, it's to the proximal interphalangeal joint. Okay, so first and second digit is a lateromedial projection. Digits 3, 4, and 5 typically are the mediolateral, meaning you're rolling the foot out towards that bump, that lateral malleolus on your ankle. This would be the inside of the foot. Right now, technically, I said 4th and 5th are mediolateral. Truly, the third digit, you can go either way. You pretty much would have to evaluate your patient and see which way it's easier for them to roll their foot, depending on what the injury is, depending on their body habitus. Some people are going to be able to roll easier one way versus another. So whatever is most comfortable and your patient's able to achieve, that's what I would go with for the third digit. But first and second are lateromedial. 4th and 5th are mediolateral. That's all to reduce OID. And the third digit can go either way because you're going to have OID no matter what you do. And for 2nd through 5th digit, central ray is to the proximal interphalangeal joint. And if it's first digit, central ray is to the interphalangeal joint. Now, when we look at the evaluation criteria, basically on a lateral toe, you want to make sure it's a true lateral. And I'm sorry if I didn't tell you the page number for the lateral toes. This is on page 230, and the obliques were on page 229. And I don't believe I said collimation. Typically on these, again, long axis of the part with the long axis of the IR, so you're going to collimate. I would tell you you're probably going to be on a 14 by 17 or a 16 by 16. So you would collimate, I believe the book pretty much says a 10 by 12, but honestly, if it's toes, you're probably going to collimate a lot tighter than that. Okay, so the digit that's presented that you're imaging has to be in a true lateral position. The interphalangeal and metatarsal phalangeal joints have to be open. The digit should be free of superimposition from the other toes. And you always want optimal exposure factors. Okay, so this is actually really good. You can see the distal portion of the toe is nice and clear. This, I believe, is the second digit. So the distal phalanx, middle phalanx are free of superimposition. Proximal phalanx and metatarsal, you're not going to be able to really pull that off. So this image is actually very good considering what they're dealing with. Again, toes are a challenge to get isolated. Popsicle sticks, tourniquets, tape, gauze, anything you can think that is relatively radiolucent is going to be your friend. Now, we also have, we talked about those sesamoid bones, the tibial and fibular sesamoid bones. So we have images that we can actually take to view these bones in case they worry about a fracture. And these are called tangential projections. So this word right here is tangential. And what that means is that you're skimming a part. Okay, it's a tangential projection. Kind of like when we did the 135-degree lateral on the wrist, and I told you it kind of picked off the pisiform bone for the wrist, and that was an additional view that some of our clinical sites do. This is almost similar to that. So this tangential view, you're going to skim the foot to look at the sesamoid bones, and this can be found on page 231. And you can have the patient supine when they do this, or you could have them prone with their foot down like this. But the sesamoid bones are right in here. So what your central ray is going to do is just come right down and skim that part and project them free of superimposition. All right, you're basically trying to dorsiflex the foot in either position so that it's at a 15 to 20 degree angle from vertical. And the central ray is perpendicular so that it skims the part. And the images that you get are isolated views of the tibial and fibular sesamoid bone. And this is the distal first metatarsal. So you can see they stick right out. They're isolated away from the rest. Here's an unlabeled image. But if there was fractures in those bones, you would actually see it. Now, as far as what they would do if they were fractured, I don't really know that they would do much unless it was hindering the patient from being able to walk or injuring the soft tissue around that. I have seen fractured sesamoids. Sometimes they'll have the patient not be weight bearing for a period of time to allow them to heal, because remember, these bones form in the first digit of the foot and the first digit of the hand. They are formed from friction. And the patella is also the biggest example of a sesamoid bone. Now we will look at imaging of the foot, and this begins on page 232. In the routine images for a foot, we do an AP, an oblique, and a lateral. And I will tell you that if your patient is ambulatory, meaning they're walkie and talkie, typically the AP and the lateral are done weight bearing. This is true of most all Advent Health clinical sites, because what the radiologists like to see is how the anatomy appears under stress or under pressure, bearing the weight of the body. Okay. Now, when I say if they're ambulatory, typically the rule of thumb is if they walked into the hospital or they drove themselves to the hospital, they might come down in a wheelchair, but if they can get up and walk out of that wheelchair, they can walk to their car. If they walked into the emergency room, into the outpatient center, then you are going to do them weight bearing. And we'll look at those images at the end. Okay, if they're not able to bear weight, then we're still going to do the AP, the oblique, and the lateral, but they just would not be standing up for those two images, the AP and the lateral. So when we look at an AP foot, it's an AP foot. Sometimes they will call that a dorsoplantar projection because you're going through the dorsal surface first and exiting the plantar surface. Okay, so the AP foot, Again, on page 232, you're going to be on a 14 by 17 with collimation. The patient is now we're not talking standing, so let's just assume the patient is sitting on the table laying on their back with their knee bent, and they place their foot on the IR. They put their plantar surface of the foot on the IR. You're going to angle the central ray between 5 and 15 degrees. Now I know it says 10. 10 is just middle of the road. Most people are going to be a 10-degree angle. But notice on page 232, it says the angle varies between 5 and 15 degrees, totally dependent on the patient's arch. And this is the longitudinal arch, okay? And remember I said to you that when you look at it laterally, the longitudinal arch is not very significant. So this is not where we want to evaluate what degree of angulation. You'd actually want to look on the medial aspect and see the patient's foot as to how high the arch is. If they have a really high arch, then you're going to need to angle 15 degrees posterior. If they're pretty much flat foot, then you're only going to angle about 5 degrees posterior. Okay, because the reason you're angling either 5, 10, or 15 is to be perpendicular to the metatarsals. Again, the foot tends to have a bow in it or an arch. So looking from the medial aspect, if they have a really high arch, then in order to get this central ray perpendicular, you're going to need to angle more. If their foot is very flat-footed and not much of an arch, then your angle is going to reduce to about 5-degree angulation. Okay, so 5 to 15, 10 is just a good middle of the road. Now, if you're looking for a foreign body in the foot, say they stepped on something and they're just trying to image to see where that foreign body is, then you're not going to angle at all. Okay, foreign body, no angle. The central ray is at the base of the third metatarsal. So you can see they've got 1, 2, third base, or the bottom of the third metatarsal. It's right about in the middle of the forefoot. Okay, so base of the third metatarsal, and your central ray central ray is base of third metatarsal. Your technique is 65 kVp at 1.2 mass. Again, technique are following the same as the hand so far. 65 at 1.2. Our next image, let's evaluate that one. When we look at the criteria on an AP foot, we need to visualize the entire foot. You don't want any rotation in the metatarsals. So when you're looking here, you shouldn't see any rotation. The metatarsal phalangeal joint should appear open. And optimal exposure factor. Now this is actually a good foot. You're well penetrated in the forefoot, which is good. Toes are not burned out, and marker is appropriate. It is to the right of the extremity, and it's up top, and it's hanging correctly so that the radiologist can read that. Next, we do an oblique foot. Okay, that is on page 233. And this is typically a 30 to 40 degree medial oblique. So again, rolling towards midline. Patient would still be lying on their back with their knee bent, and all you do is have them internally rotate their leg or medially rotate their foot so that the plantar surface, which is underneath here, forms a 30 to 40 degree angle with the plane of the IR. And the central ray doesn't change. It's still at the base of the third metatarsal. Okay, so you can see 1, 2, 3, base of the third metatarsal, still right about middle of the forefoot. All right, and your textbook says that they recommend closer to a 40-degree obliquity so that you demonstrate the tarsal bones and the proximal metatarsals free of superimposition with a foot with an average arch. All right, now when we evaluate this image, as far as it being the correct degree of obliquity, the 3rd through 5th metatarsals should be free of superimposition. So when we look, we have 3rd, 4th, and 5th metatarsal, and they are actually free of superimposition. Nice, clear, easy to visualize, everything separated. You see the entire foot from soft tissue at the top of the toes, including the ankle. Now, ideally, you should have, ankle, heel. You should have the soft tissue of the heel included as well. So I might have opened that just a smidge more on both ends so that it's not so tight. And you're also going to demonstrate this 5th metatarsal tuberosity is going to be in profile if you have the correct degree of obliquity. All right, and the joint spaces around the cuboid are open. So notice you see all the way around that cuboid. Okay, so proper degree of obliquity. 5th metatarsal tuberosity is in profile. Cuboid joint spaces are all open. 3rd through 5th metatarsals are not superimposed. Those are all important things to look for on a correct oblique of the foot. And the last image we do of the foot is a lateral, and it's actually a medial-lateral foot. Again, because when you're standing in anatomic position, this is the medial aspect of the foot. This is lateral, so the projection is medial-lateral. In order for this to be a true lateral, you have to have the plantar surface perpendicular to the IR. So you're going to be looking at the bottom of the patient's foot and making sure that this is perpendicular to the IR. And usually to correct that, you're either going to have to raise or lower their knee. Like if you raise the knee up, it'll change this, and if you lower their knee down, it will change that. So you need to have the plantar surface perpendicular to the IR. And you might have to have them dorsiflex their foot slightly if it's kind of, if there's a significant arch to it, if their toes are pointing downward, you just want to pull their toes back so that their foot is slightly dorsiflexed. And the central ray on this is to the medial cuneiform, which is still at the same level of the base of the 3rd metatarsal. The only problem is you can't really visualize that because it's over here. But if you were to bring that over to the top, you're actually at the level of the medial cuneiform. So this is good. It's kind of like when we did the lateral hand. The hand was central ray was at 3rd MCP, and then when you roll up laterally, it ends up being at 2nd MCP. Well, the base of the 3rd metatarsal on this, when you come up laterally, ends up being at the medial cuneiform. So I said cuneiform, which is still at the base of the 3rd metatarsal. All right, now typically when this image hangs, which you'll see in the next picture, it tends to hang with the tib fib up. Like this, if you were looking at the view box, this is actually how it would hang. So that marker placement is perfectly fine. But if you look on here, I mean, this would be perfectly fine too, except our IRs aren't this small anymore. They're much bigger. So this is acceptable either way, because now when it's a lateral foot, it's going to hang with the toes pointing either to the left or to the right, depending on which lateral it is. You again have to demonstrate the entire foot. You should visualize the tibiotalar joint right here. The metatarsals should ideally be superimposed to know that your plantar surface was in a true perpendicular plane to the IR. You can see this looks pretty good, and for the most part, those are pretty well superimposed. And as far as exposure factor, that is a really good lateral foot. Now, we said if the patient was ambulatory, whoops, that did not look good, does it? all this says, these images are actually on page 235. So the AP and lateral are done weight bearing if the patient is ambulatory. All right, and all this says underneath here is that it's a horizontal beam, and this is the lateral, but we'll talk about the AP first. The AP says central ray is angled 15 degrees posterior. Okay, so again, weight-bearing images, this one they're standing on a special plate that goes over the image receptor. You never want to stand the patient on a digital receptor. Those receptors probably cost minimally $40,000 to $50,000 minimum, and they go up from there. So you don't ever want a patient to stand on a digital receptor, because depending on their weight, they very well could break the receptor. So this is a special box with a specific glass that the patient's able to stand on that can maintain much more weight, and the IR is just underneath it. Okay, so the patient's standing on that, and what these images will show is how the bones react under the pressure of bearing the patient's own weight. So the patient stands erect with their full weight evenly distributed on both feet, and this is angled 15 degrees posterior to midway between the base of the metatarsals. So if you were doing just one foot, you would normally center at the base of the third metatarsal. All you're really doing is bringing that central ray to the middle, kind of like when we did the ball catcher view, or the Norgard method for the hands. Okay, so that's the AP. And then for the lateral, this particular one looks like they dropped the wall bucky to the floor, and the patient's standing on some kind of step. All right, so it's just horizontal perpendicular beam for the lateral, and the central ray is still to probably medial cuneiform at the base of the third metatarsal. And then when we look at these images, the AP weight bearing, notice that you'll see bilateral feet, and the phalanges and the metatarsals should not be rotated. Ideally, you would mark both feet. Anytime you do something bilateral, you typically mark both feet. Okay, as long as they have left, I'm sure the radiologist can figure out that this is right. It just looks better on you if you mark both images, or both sides of the anatomy. So this would be weight-bearing AP. And you're not really getting much past the tarsal bones, which is fine. As far as exposure factors, this is a little bit light, but acceptable. And then the lateral, again, you need the entire foot demonstrated. You can tell they're standing on something. The plantar surfaces of the metatarsals should be superimposed, and this is much better as far as exposure factors. So you've got soft tissue from the toes all the way back to the heel. You're including the ankle joint or the tibiotalar joint, and you can tell the patient is standing on something. So if they're able to, and they're coming in an ambulatory patient, then the AP and the lateral should be done weight bearing. And that concludes our anatomy and positioning for toes and foot. And we will discuss this in a live lecture or in a class setting soon. And if you have any questions, comments, or concerns, be sure to address them at that time. Thank you so much.